Hello, guys. How are you?
Good, thanks. How are you?
Pretty good. Can I just ask everyone how to say their names so I don't mess up saying your name?
Yes, mine's Nascimbeni.
Nascimbeni. Okay. Thank you.
Thanks for asking.
Hi, my name's Ryann Gollings.
Gollings. All right. Thank you. So what I think we're gonna do is we're gonna have 20 minutes per presenter, and that's gonna include your question time, if that's okay. So I'll probably give you like a little heads up around the 10-minute mark. How do you guys want me to give you that single? Do you want me to like review or raise my hand type thing? What's easiest for you guys?
I have a presentation, so I won't be able to see if it's like a chat or anything, because my whole screen will kind of be covered up. So I guess just maybe saying like a little like there's something like smiling might be helpful for me. I think mine's
Okay.
a little bit over 11, so.
That's fine. I'll do that. I'll just be like, all right, you're at your 10-minute mark, just so you know. And then probably around the 15-minute mark at the latest, I'll be like, all right, and we're gonna start questions, just so everyone has some time to ask. But
Yeah, that will, if that's okay with everyone else, because I won't be able to see anyone when I pull my slides up. So.
great. We're just missing. Sorry, I would like to get your last name too, but I'm excited to hear.
Sorry, my last name's pronounced Filippini, but I'm just here to watch the presentations and support a friend. I'm not presenting in this group.
Oh, sounds good. Thank you. Hi, Mary.
Hello. Good morning, everyone.
Morning.
All right, and then one more question for my presenters. Who wants to go first?
I'll do it. I'll go first.
Thank you.
I'll volunteer.
All right, sounds good. I'll start in like 2 minutes. All right, so we're gonna get started. Welcome to our session 2 for the conference. We're gonna do uncovering mental health needs in this group, and Carly Nascimbeni, I still messed that up even though I asked, from Salisbury University is going to talk about self-stigma and Black men with mental health illness and closing the treatment gap.
Everyone, I'm going to go ahead and share screen. I'm not going to be able to see once I share screen, so if the presenter could just say, we can see it, that would be great, so I can make sure we're all set. Okay, can everyone see? Okay, great. All right, everyone. So my name is Carly Nascimbeni, as she stated, and I'm from Salisbury University. My topic is self-stigma in Black men with mental illness and closing the treatment gap. Dr. David Satcher, former US General Surgeon, said, "Stigma is the most formidable obstacle to future progress in the arena of mental illness and mental health." Now, imagine having an already highly stigmatized illness on top of being both historically marginalized and discriminated against. This is a battle many Black men face today. We're going to be going through mental illness stigma, an issue known as the double burden, the treatment gap, and then finally methods to combat self-stigma. But first of all, why should you care about mental illness? Well, more than 50% of people will be diagnosed with a mental disorder in their lifetime. 1 in 5 people over the age of 18 will experience a mental illness in any given year. And 1 in 25 Americans lives with a serious mental illness, such as schizophrenia, bipolar disorder, or major depression. So in section 1, we're going to go over public views, then self-stigma and the effects. I'm going to start out with this quote just to kind of give you an idea of how stigma plays into mental illness. That's the stigma, because unfortunately we live in a world where if you break your arm, everyone runs over to sign your cast. But if you tell people you're depressed, everyone runs the other way. That's the stigma. We are so accepting of any body part breaking down other than our brains. And that's ignorance. That's pure ignorance. And that ignorance has created a world that doesn't understand depression, that doesn't understand mental health. Okay, but first, what is stigma? Stigma is actually a multifaceted conception, which depends mostly on subjective outlooks, and there are many perceptions. So we have the stigmatizing views a person has regarding others, The stigmatizing views a person has regarding themselves, which is also known as self-stigma, which you're going to hear many times. Perceived stigma beliefs regarding the views that others hold, stigma that occurs through the media, and finally, stigma that occurs through experiencing the discrimination firsthand. Now, here are your public stigma contributors. There are 4 main contributors to public stigma, and most of these contributors may surprise you. Friends are actually one of the biggest perpetrators of microaggressions towards people with mental illness rather than strangers or acquaintances. Microaggressions is a term you're going to hear again, but they're overt and non-overt, recurring, daily degrading and demoralizing indignities directed at historically marginalized populations. Next, we have family. Families often report that friends, neighbors, and coworkers often blame them for their relative's mental illness, which actually exacerbates the burden that those family members feel. Another surprising contributor are actually psychiatrists. Psychiatrists are more pessimistic about mental illness compared to other practitioners. In addition, they are more likely to endorse stereotypes about the mentally ill being dangerous or unpredictable. And finally, in the bottom right-hand corner, we have the media. The media most often displays people with mental illnesses as being violent and unpredictable. So how does public stigma lead to self-stigma? Well, I have provided some examples in this slide. Your friends or colleagues might say things like, you're using this as an excuse not to do your work. And your family may make snide comments such as, don't invite Carly to dinner, she'll probably just be in a bad mood the whole time. Meanwhile, psychiatrists may say things that perpetuate the stigma by relaying that people with mental illnesses are dangerous, all while the media is displaying people with mental illnesses as being dangerous. These all lead to internalization of public views. One may start to second guess themselves, feel unloved, or even start relating themselves to those negative stereotypes that others are portraying. The sociodemic variables with the highest relation to self-stigma are low education, low-level social support, unemployment, and most importantly for our topic, identifying as male. So how did this all come together? In other words, how does all of this stigma affect someone with mental illness? Well, there's low adherence to treatment, a lack of self-efficacy, hopelessness, and then finally a reduction in self-esteem. So let's go ahead and add our next layer in. We're going to be talking about double burden, microaggressions, and discrimination, and the effects. First of all, what is this term double burden? Being a part of a marginalized population group and having a mental illness is referred to as a double burden. However, I want to be clear that the burden should not be looked at as being a part of the marginalized group. The burden is the discrimination that is typically received as a result. Similarly, with mental illness, the burden should not be looked at as having the mental illness or mental health concerns. The burden is dealing with the stigma that is associated with that mental illness. I touched on this topic earlier about microaggressions, but microaggressions are a contemporary form of racism, which displays itself in subtle manifestations of disregard, disrespect, and neglect. In fact, research indicates that Black men often report microaggressions in which they are perceived as inferior, less educated, poor, or inarticulate due to their race. One of the most common examples of this would be saying, you don't sound Black, which suggests that most Black men are not educated, leading to a negative self-concept relating to one's own race. And research actually shows that these cumulative effects of minority stress often take a toll on one's mental health. First, I thought it was interesting to note that Black people who have attended college often feel more discriminated against than those who did not attend college. One of the leading sociodemographic variables of self-stigma that I mentioned earlier was low education. However, in this instance, the pursuit of education is leading to further discrimination, which contributes to self-stigma. The second graph represents Black men specifically and how they are often unfairly stopped by the police. Do you remember how I told you people with mental illnesses are often stereotyped and portrayed as violent? Well, Black men actually with mental illness are facing this stereotype twofold. So how does racism and discrimination mentally affect Black men? Well, there's poor self-concept, internalized racism, which is the acceptance by marginalized racial populations of the negative societal beliefs and stereotypes about themselves. We have negative affective responses, which may include anger, contempt, disgust, guilt, fear, nervousness, self-devaluation, increased rates of depression. We have suicidal ideation, poor mental health outcomes, and health damaging behaviors, which may include behaviors that contribute to unintentional injuries, tobacco use, alcohol, other drug use, and even risky sexual behavior. So how does this all add up? Well, it leads to a treatment gap. The treatment gap for mental disorders refers to the difference between those who need to seek care for mental illnesses and those who actually receive the care that they need. what is the treatment gap in the United States? In 2018, 50.1% of Black adults ages 26 to 49 with serious mental illness did not receive treatment. Black men are particularly concerned with stigma and self-stigma, which I found out after I began my research. Stigma and self-stigma put Black men at a higher risk for disengagement. There's also fear of a label. If Black men are already fearing stigma, then having the direct association with mental illness by receiving a psychiatric label will be particularly hard for them. Black men are also more likely to receive a serious mental illness diagnosis, and this will create another barrier for them as they are already fearing a label in general and the stigma that is associated with that. So associating with a serious mental illness label will be even more challenging. I wanted to share a few quotes with you from Black men discussing mental health with the Black Mental Health Alliance to further reiterate the underlying social and cultural issues that affect Black men. First, we are not supposed to seek help for our mental illness. There's still a lot of stereotyping of Black men in all of the medical professions. We have a problem asking for help, especially from folks who we think are the reasons for our mental illness. No Black man in America is ever mentally healthy and who really, really gives a damn about the Black man in America. So what are the implications of leaving a mental illness untreated? Well, we have ruined relationships, unnecessary medical procedures, psychiatric hospitalization, job loss, substance abuse, and suicide. So we must do something, right? Well, here are some methods to reduce self-stigma. First, we have training and awareness campaigns. Numerous studies suggest training and awareness campaigns reduce perpetrations of microaggressions and their impact. Next, we have family involvement. Family involvement is a rare occurrence in the treatment of mental health, but is also crucial to the patient's recovery. This is of particular importance amongst members of minority population groups who are more likely to live with family members, including family members in mental health treatment, will aid in educating family members about the effects of stigma and lead to a reduction in self-stigma amongst Black men. Next, labeling of the mental illness. I know this was originally listed as a barrier, and it certainly is one. However, it can also be someone's saving grace. By receiving a psychiatric label, there would be an increase in available options for treatment. You may also begin to associate with the stigmatized group that has the same mental illness you do. And here's a little fun fact. People who start to associate with a marginalized population group often find growth and support. And those that associate with the group and figure out they don't really want to associate with that group anymore are more likely to adhere to treatment. So either way, this is going to end up working in their favor. Next, and perhaps most importantly, incorporating social and cultural perspectives into mental health treatment has been deemed a moral and ethical responsibility of providers because of its overwhelming research on the impact of treatment seeking and adherence. There are simple interventions providers can take in order to assist their patient in building trust and confidence. Examples include asking the patient what will help them feel respected and inquiring about their cultural history and identity, or involving community members or religious or spiritual support. Next, you'll see we have increasing diversity of mental health care providers. As of 2015, only 4% of psychologists in the US were Black. Increasing the diversity of mental health care providers may aid in increasing the trust and confidence of healthcare services amongst Black men. Meanwhile, providers are still able to provide empathetic communication and collaboration with their patients. Studies show that involving patients in the treatment decision-making process by asking their opinion and preferences increases adherence to treatment. Then there is challenging stigma. One way to do this is through the principle of proximity, which has shown that the more experience someone has with someone who differs from them, the more likely they are to accept them. Therefore, if you are able to combat stigma by coming out about your mental illness and sharing with others, the more likely they are to relate that positive experience they have with you to a positive experience with mental illness, which works to combat public stigma. A few relevant organizations that work to combat stigma and provide support are Mad Pride, Black Mental Health Alliance, and Healing While Black. In conclusion, unpacking all of the layers that go into the mental health concerns Black men are facing can seem daunting. However, organizing the target areas by priority in order to decrease one disparity at a time has been deemed effective. Using a combination of socially and culturally relevant approaches, information, and resources geared specifically towards Black men and their unique challenges should lead us towards closing the treatment gap. Thank you very much.
That's awesome. If you guys have questions, just like raise your hand and we can call it out, or if you want, you can type it in the chat and I'll read it and Carly will answer. Go ahead, Mary.
Okay, thank you so much, Carly, for your presentation. It's such an important topic in today's world, so especially in academia. Considering the social psychology of some of these issues and like you had mentioned, the way friends and family or the culture that you're raised in influence some of the stigma. Do you believe that, or from your experience, do you think there's any aspect of our culture nowadays that specifically makes this worse in our society, such as maybe breakdown of the traditional family within the past 50 years?
I think there are some things that might make it worse. Like, families aren't, divorce rates are higher, so we don't really have that family base as much as we used to. However, I think also with time, people have become more open about dealing with mental health issues. I mean, I know that it's become very common amongst my friend groups, particular, to just talk about seeing a therapist. And I think that is something that has really increased over time. If you look back 20, 30 years, I don't think people were as comfortable talking about their mental health needs. But as you've seen culturally, it is a little bit different amongst Black men. And so I'm hoping that sort of with that change of culture, they'll kind of, start to grow with that as well and understand that mental health needs are just like physical health needs. And so hopefully, even if some of those family values can't be there, they can still be there if families are separated, certainly. But kind of growing with, kind of what I've seen recently amongst my friend groups, I think that that will be helpful.
All right, we have a question from the chat. Do you think there's a significant access barrier in societies with economic disparity to receiving proper mental health treatment?
I absolutely believe that there is. First of all, mental health treatment is normally very expensive, even for people that have very good health insurance. Oftentimes, it's even hard to get access to mental health, which I think is, it's really a barrier for all people, but specifically with people, from disadvantaged population groups that might not, have the means to pay for things like that. And I think that's something that certainly needs to be addressed. It should be looked at, again, more like a physical illness or disease. And so hopefully, insurance will start to cover more of those needs. So that way it's more affordable to people and that access is easier. And I think also by having to kind of combat that barrier, it sort of adds to the stigma. A lot of people don't want to have to jump through all of these hoops, right? When they're dealing with mental health issues. So if they're having to deal with these concerns of how to pay for it, it's just another barrier that they shouldn't have to go through.
Hi, Carly. Wonderful presentation. I think it was amazing. I actually did my research on something similar, but for Arab American groups in northern New Jersey. You also mentioned how the cost of mental health services is a huge barrier for seeking out these mental health services that a lot of people need, specifically minority populations. Though minority populations are just as likely as non-minorities to experience mental disorders, they're far less likely to seek out treatment for them. So what do you think we can, what are some steps that we can proactively do to kind of combat this stigma in these minority communities?
I think that's a great question. So I think it would just be increasing the conversation to let people know, kind of what's out there and what's available. And also I think, particularly in the day of social media with a lot more people coming out about their mental illnesses or their mental health concerns, I think that helps people to understand that a lot of people are facing these issues, and then it becomes more normalized. And I think that that will be very helpful for people, so they won't feel like, oh, wow, like I have this mental illness and I'm very different from other people. Truly, like, as you can see from the stats that I presented, it's so normal. And I hope that by increasing that level of conversation and having it just be a part of daily conversation, people aren't nervous to say, I went to the doctor because I broke my leg, but people are very nervous to say, I'm going to the doctor because I have depression. And it should be on the same level as far as I'm concerned.
All right, we have time for about one more question. If no questions, thank you so much, Carly. That was a great presentation. Which one of our presenters would like to go next?
I can go.
Great. All right. So I'm gonna try and time it that like when you're on an end of a slide, I'll try and poke in and be like, here's your 10-minute mark. All right, so Ryann Gollings from Thiel College is going to present the association between paranormals and feeling of stress, anxiety, and depression. I'm sorry.
It's okay. I'm going to share my screen here. Okay, so have you ever wondered why sleep talking and sleepwalking occurs in some and not others? Or why it occurs in children more often than adults? So I want everybody to ask themselves, have I ever sleepwalked or sleep talked, or has someone ever told me that I did? I personally have never sleepwalked, but I have encountered others doing it, and I've talked in my sleep before. And so this is what led me to do this research. This video highlights some of the possible triggers and what researchers think of sleepwalking.
Hey there, welcome to the situation if you do. But with all that said, why does sleepwalking occur in the first place? Well, one hypothesis is that people rise from their beds when their brain attempts to go straight from non-REM sleep to being awake, rather than going through the rest of the sleep cycle. And it's thought that something triggered this transition. This is the part that scientists are still not sure on, but they have a few ideas. As mentioned before, sleepwalking mostly occurs in children, so some scientists think that children are more prone to sleepwalking because their brains aren't yet fully developed. It may be that all of the growth hormones are triggering the kid to rise, but it may also have to do with inhibitory neurotransmitters. See, there is a neurotransmitter called GABA that stifles the brain's motor system. For adults, this neurotransmitter usually does a good job to inhibit the body's motion, but for kids, the neurons that release that neurotransmitter aren't fully developed yet, so their motor systems may still be active. And voila, this can lead to the kid walking around their house in their sleep, or riding a skateboard juggling chainsaws wearing a top hat. I don't know. Now don't worry, children usually grow out of sleepwalking as they age and their brains fully develop. But if sleepwalking persists into adulthood, it may be linked to a mental disorder like alcoholism or clinical depression. Most of the time, it's not dangerous, but if it gets to be, you may want to seek out a doctor for help. So have you ever sleepwalked before? And if so, what did you end up doing? Knowing me, I would end up eating leftover pizza right out of the fridge, but that's assuming I can sleep at all. Hey animator, can I sleep? Cool, thank you. Anyway, make sure you come back.
All right, so to look more into the why, I was interested in studying the association between parasomnias and the variables of stress, anxiety, and depression for my thesis. So for my study, I hypothesized that the more feelings of stress, anxiety, and depression an individual has, the more frequently and severe their parasomnias will be. So parasomnias are defined as sleep disorders that are abnormal behaviors or psychological events that can happen during the transitional stage between sleep and waking, such as sleepwalking, sleep talking, night terrors, sleep paralysis, and even teeth grinding. So in my conversation with people who've experienced parasomnias, they've also wondered why or what is causing their parasomnias. And they've brought up things like stress, anxiety, and depression as possibilities. So I thought it would be interesting to see if others thought this as well, and if there was statistical evidence for this observation. So like the video had stated, there's not much known about particular triggers, and some explanations could be sleep deprivation, stressful events, or environmental factors like a fever or a full bladder. One study showed that sleepwalkers tended to experience more daytime sleepiness, depressive symptoms, and insomnia symptoms. Another study looked deeper into sleep talking and noise utterances during sleep, found that most episodes are nonverbal noises like crying or mumbling. But for speech episodes, they looked at tone, word analysis, and even the silence for turn taking during a conversation. And they found that people will typically follow language gaps for turn taking, and that men sleep talk more often than women. Still, the question is why these parasomnias happen. So one case study focused on an 18-year-old female who was experiencing episodes of sleepwalking. She took the Beck Anxiety Inventory and began cognitive behavioral therapy. And after a diagnosis of generalized anxiety disorder, many therapy sessions, and some medication, her parasomnia stopped, and it was thought that her anxiety was a trigger for her sleepwalking. This study had been one of the only scientific studies trying to link parasomnias to mental health. So I wanted to look further into this and on a broader scale. Through my study, I was hoping to see a positive correlation between parasomnia scores and levels of stress, anxiety, and depression, and that as these variables increase, parasomnia scores would also increase. So I set out to answer this question by conducting a mixed methods study with quantitative and qualitative portions through survey and interview, respectively. There were 107 participants, all college-age students from Thiel College. The 9 interviewed participants also were included in the 107 participants in total, and it also completed the survey. Participants' ages ranged from 18 to 24, with an average age of 19, and most participants were female in both the quantitative and qualitative portions at 80% for quantitative and 78% for qualitative. The quantitative part of the study was completed entirely online using the Qualtrics platform. Participants completed measures concerning parasomnia, stress, anxiety, and depression from previously validated studies. The Munich Parasomnia Scale had 14 questions where participants answered how often they experienced different parasomnias on a Likert scale from behavior was never observed by me or others to very frequently occurring every or almost every night. Participants were asked if they had experienced parasomnias such as grinding their teeth, sleep paralysis, nightmares, sleepwalking, and sleep talking. If participants had ever experienced any of those behaviors, they were asked a follow-up question of whether it was self-observed or observed by others. The perceived stress scale had 10 questions asking in the past month how often they had felt or thought a certain way on a Likert scale from never to very often. For example, they were asked how often they felt confident about their ability to handle personal problems. The Beck Anxiety Inventory had 21 statements asking in the past month how much each of the symptoms had bothered them on a Likert scale from not at all to severely and that it had bothered them a lot. Participants were asked to consider symptoms like their inability to relax. The Beck Depression Inventory had 21 questions asking participants to select between 4 choices that best fit them. For example, one question asked to choose between I don't feel guilty, I feel guilty a good part of the time, I feel quite guilty most of the time, and I felt guilty all of the time. For all of these measures, I calculated a single score for each participant that represented the severity of their symptoms, calling this the Parasomnia score, their levels of stress, their levels of anxiety, and their level of depression. During the interviews, the participants answered open-endedly on questions relating their parasomnia experiences to stress, anxiety, and depression. And to get a better understanding of their parasomnias as individuals, they were first asked questions like how often they experience parasomnias, if they notice any patterns in their parasomnias, and what are some things that they did in their sleep specifically. Each participant was asked if they thought stress increased their experience of parasomnias, if anxiety increased their experience of parasomnias, and if depression increased their experience of parasomnias. So I conducted the interviews to get a better understanding of the possible triggers to see if others also believe that stress, anxiety, and depression could be potential triggers for them. So what did I find? As a reminder, I set out to find if there was a positive correlation between these variables, and if so, if it was significant. For the correlational results, I focused on the p-value and r-value to test significance. The p-value is measured between 0 and 1. The smaller the p-value, the more significant the results are, and are considered statistically significant when below 0.05. The r-value showed the strength and direction of the relationship and is measured between -1 and +1. The further away from 0 the results are, the stronger the relationship is, and the sign in front of the results shows whether it's positive or negative. So first, I looked at the association between parasomnia scores and stress levels. I conducted a Pearson correlation analysis using these 2 variables, and my results showed that this correlation was significant. The r-value showed a moderately positive correlation, and the p-value was less than 0.05, meaning it was statistically significant. So the higher the stress level score the participant had, the higher their parasomnia scores were. I then looked at the association between parasomnia scores and anxiety levels. Again, I conducted a Pearson correlation analysis using these 2 variables, and my results showed that this correlation was also significant. The r-value showed a strong positive correlation, and the p-value also showed statistical significance. So the higher anxiety level score the participant had, the higher their parasomnia scores were. Lastly, I looked at parasomnia scores and depression levels, and again conducted a Pearson correlation analysis, and my results showed that this correlation was also significant. The R value showed a weak positive correlation, and the p-value showed a statistical significant correlation. So the higher depression level scores the participant had, the higher their parasomnia scores were. Across the board, it appears as if parasomnias are connected to people's levels of stress, anxiety, and depression. So what did I do with this information? After finding this support for my hypothesis, I broke up each correlation into low, medium, and high levels of stress, anxiety, and depression so I could better understand the association. I wanted to examine if there were significant differences in parasomnias when people reported different levels of stress, anxiety, and depression. So first, I examined the relationship between levels of stress and parasomnia scores. The mean score for low stress was 17.2. The mean score for medium stress was 22.2. And the mean parasomnia score for high stress groups was 24.13. So the p-value showed that this test was also significant between the low and high levels of stress groups. Participants with higher stress levels had a higher parasomnia score. And as you can see here, the parasomnia scores steadily get higher as the stress levels also get higher, showing that the hypothesis for stress was supported. Next, I examined the relationship.
You're right at 10 minutes, just so you know.
Okay. Next, I examined the relationship between levels of anxiety and parasomnia scores. The mean score for the low group was 15.97. The mean score for the medium group was 19.42. And the mean score for the high anxiety group was 28.43. So the p-value showed that this test was also significant between low and high levels, and medium and high levels. So participants with a higher level of anxiety had a higher parasomnia score. And as you can see again, scores steadily get higher as anxiety level also gets higher, showing that the hypothesis for anxiety was also supported. Finally, I examined the relationship between levels of depression and parasomnia scores. The mean score for the low group was 17.43. The mean score for the medium group was 21.61. And the mean score for the high depression group was 24.35. So the p-value showed that this test was also significant between low and high levels of depression groups, and participants with high levels of depression had a higher parasomnia score. Again, here you can see the parasomnia scores get higher as the depression level also gets higher, showing that the hypothesis for depression was supported. So when the interview participants were asked if they thought stress, anxiety, and depression increased their experiences of parasomnias, they answered with mostly yes, or at least probably. So when asked why they believed they had parasomnias, 2 participants brought up stress as a possible trigger before it was even asked. And I also asked participants if they could recall anything specific happening before or after an episode of parasomnias that could have potentially triggered them. While most answered no, one participant stated that theirs had started after a traumatic event occurring in their life. So there was some hesitation when saying that a depressive mood might increase their experience of parasomnia, saying that it was possible, but not as much. And like the survey data suggests, a depressive mood does not have as high of an association as stress and anxiety. Overall, the hypothesis was supported with the significant differences in parasomnia scores when looking at levels of stress, anxiety, and depression. And being that there's not a lot of scientific information on this topic, finding that these 3 mental health variables were significant allows for people who experience parasomnias to think further about their amounts of stress, anxiety, and depression in their daily lives. And by trying to lower these can potentially lower the frequency or severity of their parasomnias. This study was conducted during the COVID-19 pandemic, potentially leading to higher responses of stress, anxiety, and depression levels across the board. The interviews had also been conducted over Zoom, so I believe that this could lead to a barrier between interviewer and interviewee, where responses are a little bit more sparse than if they were able to be conducted in person. This study could be replicated in times of less unease for a general population. And I think that this might change the findings slightly and that their levels of stress, anxiety, and depression would not be as high. But if these were true triggers for parasomnias, the parasomnia scores might also be lowered. Having these results I was looking for in the study, I'd love to further this research and potentially conduct an experiment with participants of high parasomnia levels and frequencies. And to do this, I would try to induce an everyday stressor, nervousness, or a sad mood to conduct a sleep study to see how their parasomnias are impacted. Thank you. And these are my references. So, yeah.
Good job.
Okay.
That's awesome. So same deal as last time. You can send your questions in the chat or just raise your hand and such. But Definitely.
Thank you so much, Ryan, for your presentation. I have one question. Do you think that given that the brains of females are not fully developed until around 22 to 24, and for males 26, do you think conducting this study or replicating it with an older population would change the findings?
That's a great question. I think that it's very possible. And I think it would also be interesting to conduct this with also younger children, since it did say that children experience parasomnias more often. But I'm not sure how exactly I think it would change them, but I think it might.
I have a question. For your future research, do you have ideas what you would want to have as like the consistent stressor that's like also not super harmful?
So I think I could conduct stressors like, telling them that they have like a meeting in a few minutes that they might be late for, things like that. Nothing like too crazy, just like an everyday stressor that people normally would have, just so that obviously we wouldn't want to cause people too much stress.
What was your favorite part about doing the research?
I think my favorite part was actually analyzing the data. It was very exciting to see that something that I had thought in my brain would happen actually did. So that was probably my favorite part.
Very nice. Does anyone else have any questions? Okay. Thank you so much for presenting, Ryan. Who would like to go next, Mary or Greta? Oh, wait. Sheila, was that a question? Oh, okay. Who would like to go next?
I can go.
Great. Greta?
Let me just share my screen here.
I'm sorry, I don't know how to say your last name, but
Gemuriman. It's okay, nobody ever does.
I also have really bad stutter sometimes. Greta Gemuriman from Macaulay Honors College is going to present about pandemic university college students' mental health during the time of COVID.
Yes, and specifically how social media is saving our mental health. So I want to begin by having everyone imagine what they were doing the first week of March in 2020. Passing friends in hallways, hanging out between classes, grabbing lunches and dinners, going to parties, seeing significant others, shaking hands, hugging, kissing, and the like. So on March 11th, with 700 newly confirmed coronavirus cases, the decision was made to close CUNY campuses until further notice. Millions of CUNY students were separated from friends, peers, professors, support faculty, and campus services. SUNY students, who were under the impression that their spring break had been extended, while campus facilities are deep cleaned and disinfected, are forced to return to campus no matter how far and pack their belongings as colleges' campuses were closed indefinitely. So life as we knew it came to a screeching halt. This was detrimental to college students' mental health. Humans are a social species and thrive off human interaction. We needed to support our physical and mental health. Taking that away will cause high levels of stress in any sample population, and college students are no different. College students already experience immense levels of stress as a result of their coursework, expectations for their futures, and responsibilities to themselves and others. One of the simplest ways to alleviate this stress is to co-suffer with peers and friends in the same boat. Lacking the ability to physically interact with peers and have face-to-face conversations, whether about their struggles or not, strips the developing minds of the socialization necessary for human functioning. Most lifetime mental disorders have onset during or shortly before the typical college age and are exacerbated by the numerous stressors of college life, including irregular sleep schedules, fluctuating interpersonal relationships, and both personal and academic pressures. So in a 2007 study performed by the University of Michigan that analyzed prevalence and correlations of depression, anxiety, and suicidality in college students, 13.8% of undergraduate students reported major depressive disorders, and 4.2% of undergraduate students reported panic or generalized anxiety disorders. A more recent study performed by the American Psychiatric Association reported that 21% of college students, 21% of college students presented to counseling centers with severe mental health concerns, and another 40% presented with mild mental health concerns. So this is where coping mechanisms enter the conversation. Sitting at home might seem simple enough, but being confined to one's home for months at a time with little to no contact with the outside world can create an immense amount of stress. Coping mechanisms are used to manage an external situation that is creating problems for an individual, and there are two types: emotion-focused and problem-focused. Emotion-based coping is helpful when you need to take care of your feelings. You don't want to change your situation or the circumstances are out of your control. Some emotion-based coping mechanisms include meditating, exercising, cooking, reading a book, or listening to music. Distraction behaviors, essentially. Problem-based coping is helpful when you need to change your situation, perhaps by removing a stressful thing from your life so you face the problem head on. Some problem-based coping strategies include asking for support from a friend, creating a to-do list, or working on time management. So I conducted a short survey using Google Forms in which I asked CUNY and SUNY students a simple question. What are some coping mechanisms you've noticed that have developed over the course of the COVID-19 lockdown that you didn't have before? I prefaced this by asking whether or not individuals felt an increase in amounts of stress, anxiety, or symptoms of depression, specifically exhaustion, disinterest, sadness, and a lack of productivity. I received copious responses and was pleasantly surprised to find that students were so willing to share the things, both good and bad, that helped them make it through the day. So out of 69 respondents, 88.6% responded yes to feelings of increased amounts of stress and anxiety, and 82.9% responded yes to feelings of exhaustion, disinterest, sadness, and a lack of productivity. These are just a few of the responses I received that detailed various coping mechanisms, and many respondents felt that their coping mechanisms were constructive rather than destructive. So in the age of physical disconnect, social media is more important than ever in giving people, particularly adolescents and young adults, a small semblance of social interaction. The American Psychological Association's Social Media's Growing Impact on Our Lives, social media has done more to help adolescents and young adults socialize than many would think to acknowledge. Where global circumstances have restricted us from spending time with each other, we have turned to social media to reconnect with the world. Social media also has a hand in commiseration and solidarity, the co-suffering that I spoke about earlier, a concept that is critical for college students in knowing that they are not alone in their suffering. According to the 2019 technology.org article, Social Networking Sites and the Positive Impact They Have on Society, social media helps foster feelings of empathy. This is evidenced here by an Instagram meme which reads, "I haven't started either," are the most comforting words for a student, myself included. It is clear that society is commiserating together, and college students are no different. The pandemic has only propagated the connections that college students seek through social media platforms. A prime example of this is TikTok. I've come across numerous TikToks depicting college students going about their days during this pandemic. They show students isolated in their bedrooms, staring at their computer screens for hours at a time without any interaction except for the people on their screens. Some even show students rolling out of bed to face their computers only to roll back into bed once their classes have finished. Many of them speak of the depression, burnout, and social anxiety that has developed as a result of a lack of human contact. While this isolation is not without a legitimate reason, the frequency of these TikToks in general reports of skyrocketing stress, anxiety, and depression from college students across the nation are alarming. Here is an example.
Hey man, how are you doing? I just had my first anxiety attack in 8 years. My best friend's dad just passed away. My other best friend is in the hospital and I can't even contact her. The girl I was seeing finally committed to me, and then 5 hours later she made out with another guy in front of me. My other friend's mom got diagnosed with stage 4 cancer. The sheer amount of work I have to do is nauseating. I don't even know where to start. I can't seem to focus nowadays because I keep seeing Asian Americans being attacked and murdered. I hate looking at myself shirtless in front of the mirror. I really feel like I've let myself go. I feel terrible. I have hundreds of DMs in my inbox that I haven't responded to. My mom and my stepdad are getting divorced. Because of that, I lost my health insurance. I want to leave New York City so badly, but the main reason I'm still here is because I'm trying to help out someone in need, and they're not even responding to me anymore, and everyone keeps asking how they're doing, and I have no idea. I wish that was my answer, but I said pretty good. The original question.
The original question of, are you okay? How are you doing? So, a study performed by Western Michigan University on the impact of social isolation resulting from the COVID-19 pandemic on mental health found that social isolation is a very strong predictor of stress, anxiety, and depression. Another study performed by Professor Brigham Young University found that social isolation heightens health risks as much as smoking 15 cigarettes a day or developing an alcohol use disorder. Dr. Maggie Mulqueen, a psychologist, brings up an important point in a PBS interview that social distancing does not mean social isolation. And this is where social media plays its largest role. College students can and should still maintain as much of the level of socialization that was possible before COVID-19. Yes, the comfort of a hug or a shoulder squeeze is missing, but the connection between people can still keep growing, even through something as simple as a funny meme.
Hey man,
Sorry. On the subject of physical isolation, one of the most difficult things to develop and maintain are romantic relationships. Some may ask, what's the difference between a platonic relationship and a romantic one? The answer is quite simple. Romantic relationships offer a physical connection that most platonic relationships and friendships lack. Yes, a COVID-free friend or acquaintance can offer the comfort of a hug, but little can compare to the feeling of hugging, kissing, or touching the person you love. In asking some friends about how their long-term romantic relationships changed because of lockdowns and quarantines, I received mixed responses. One friend spoke of her 3-year relationship. It was hard not seeing each other in the beginning because we're so used to seeing each other often, but nothing really changed between us. Another friend responded about her relationship of the same length. We didn't see each other from March until the end of May. It was frustrating. Texting was only doing so much. For a couple that sees each other all the time, it was a big shock, but I think it made us appreciate our time together more. So in the 2021 article, Love Blooms, COVID-19 has changed dating during college, but hardly stopped it, the authors make the important point that college students are being much more careful about who they interact with in person. In a 2020 CNN article, Love in the Time of Coronavirus, the author explains that dating during a pandemic has given rise to new realms of consent regarding meeting new people, wearing masks on the first date, and being less than the socially distant 6 feet apart. Amanda Lane explains in her 2021 article, How Are College Students Navigating Romantic Relationships During the Pandemic, that the lack of in-person interaction, and therefore the potential for courting, has increased the popularity and meaning of dating apps such as Tinder, Hinge, and Bumble. The author of the CNN article gives numerous examples of couples meeting virtually and then physically through the use of dating apps. And this is a further testament to the importance of social media in facilitating and maintaining relationships, romantic or otherwise. Social media is saving our relationships, our nerves, and ultimately our lives. Thank you.
That's awesome. Thank you so much for presenting. Does anyone have any questions? Yes? No? Okay. I have a question. So besides being a student, what was like the main reason that you started doing this research?
I've always been a really big advocate for mental health, and I think it's really important that we focus on student population specifically, because even though a lot of schools have mental health resources, they're not always the greatest, and a lot of populations are kind of left out, I would say. the mental health resources at schools aren't reaching as many people as they should be. So I think it was really important to do the research and kind of highlight the importance of support programs like that. And ultimately, this presentation was meant to be like a call to action for mental health resources and mental health professionals to like help college students. They really need it.
Thank you. We have a question from the chat. What is your response when people, often older generations, say social media platforms are destructive?
So then I would give them a lot of the statistics that I gave in the presentation. I would just tell them, well, you can't, especially in a time of physical disconnect and like physical separation, there's no other way for us to communicate except through social media. And plus, how do I phrase this correctly? Parents are becoming a little bit more strict with their children, and in terms of how much time they can be spending outside or with their friends or not doing work, extracurricular activities. So students, especially like high school students, adolescents, and young adults, are using social media as a means of keeping in contact with their friends, even though they all have their own separate stuff going on. So that would, I think social media is really important for being able to keep contact with each other, especially now in a pandemic.
Does anyone else have any questions? We have one last question. We'll go to our last presenter. But besides social media, through your survey, what do you think was the most common like coping mechanism students had?
They were all really mixed, actually. I saw a lot of people talking about exercising, going on long walks, running, taking the dog out 17 times a day. And I also saw a lot of people responding with like alcohol use or drug use, smoking cigarettes, smoking marijuana, nobody really held anything back, I would say, during this survey. And I think that was really refreshing to see, especially because some people might be more hesitant to share like their negative coping mechanisms. But I think it was really helpful in understanding like the scope of what a coping mechanism can be for each person. I know for me personally, I was watching a lot of Netflix, painting, also going outside, taking the dog out 17 times a day. But yeah, I think it was really helpful to see who does what, kind of. Yeah.
Well, thank you so much for your presentation.
Thank you.
We have our last presentation by Mary Wielgos from Fairleigh Dickinson University about a study of mental health and wellness among professional ballet dancers.
Yes, thank you so much. Give me one moment to pull up presentation mode. My Zoom bar is not disappearing. Okay, everyone can see my slides?
Yep, you're good.
Okay, thank you. So hello, everyone. Thank you for the introduction. Again, my name is Mary Wielgos, and I am a first-year student at Fairleigh Dickinson University in New Jersey. And today I'm presenting my literature review research paper, Not on Pointe, a study of mental health and wellness among professional ballet dancers. So when many of us think of professional ballet, an experience like the Nutcracker may come to mind. Usually a family tradition to go see the Nutcracker around Christmas time, Little girls worship glittering costumes as parents enjoy the classical music. And let's face it, most brothers are reluctantly forced to go. Some of us think of professional ballet one step further, already aware through the media of the prevalence for eating disorders within the world of professional ballet. In fact, eating disorders, as well as substance abuse, drug addiction, and pervasive anxiety and depression are all extremely common within the world that is so classically revered and glamorized. So why is this? According to a study published in the Journal of Aggression, Maltreatment, and Trauma, teenage ballet dancers who are at critical stages of emotional development as they athletically train and prepare for a career in ballet regularly experience feelings of humiliation, guilt, vulnerability, and shame due to harsh criticism and ridicule by instructors, all which linger in adult psyche. A questionnaire study performed by the University of Croatia on the Croatian National Ballet Theater showed that by adulthood, 44% of male ballet dancers are regular alcoholic binge drinkers, and 63% of female ballerinas take unsupervised isotonic nutritional supplements, defined as nutritional shakes intended to provide additional vitamins and nutrients for meal substitution. In addition, 50% of female supplement users state they began doing so on their own accord, with no recommendation or supervision by a physician. To continue suppressing appetite, nearly 1 out of 5 female dancers smoke cigarettes. Both of these techniques are utilized due to extreme environmental pressure to be thin and conform to the cultural belief stating that a skinny ballerina appears to have more aesthetically pleasing arm and leg extension lines from the audience perspective, while also being easier for male partners to lift in the air. This pressure and the disease of addiction are compounded by a lack of support from employers and the global ballet community, resulting in isolation at a critically emotionally vulnerable state. In fact, it was found that 88% of females suffering from addiction issues are so isolated they would not trust disclosing the issue to anyone, even a physician. Shifting towards pressures put on males, 1/3 of male ballet dancers classified themselves as daily alcoholic binge drinkers, with binge drinking being defined as drinking heavily in a short period of time for the purpose of being drunk. 22% of males admitted to binge drinking 2 to 3 times during the week. This is due to similar expectations as females placed on the physique of males, needing to be strong enough to effortlessly lift the ballerina above their head without their muscles appearing bulky and ungraceful. This is compounded by further mental stress present in males who tend to feel responsible for both the success and safety of their female partners, as well as that of their own careers. Unfortunately, despite these extreme mental pressures, we again observed the lack of support provided by companies and the greater ballet community, making dancers feel isolated in a time when emotional support is critical. Similarly to females, 78% of male ballet dancers do not trust disclosing any kind of addiction problem with anyone, including their physician. Furthermore, injury plays an important role in mental health issues within professional ballet. Like all athletes, ballet dancers are subject to musculoskeletal injury, such as foot and ankle fractures, sprains, and ligament tears. Specific injuries are risked during partner work. For men, these include wrist and hand fractures, shoulder and rotator cuff sprains, and ligament tears, while women may suffer potentially career-ending head or spine injuries as the result of being lifted high in the air. The impact of an injury on a dancer's mental health can be severe. However, while other athletes in sports may be encouraged to seek counsel with a sports psychologist, ballet companies and studios typically do not employ this resource for the benefit of their dancers. According to a study of 20 female ballerinas evaluating their experiences of emotional harm throughout their career, acknowledgement of injury itself is seen as weak and discouraged by peers and mentors. When dancers do come forward, they experience limited support and complete social isolation. This is predominantly true during peak performance season, when an injured dancer is forced to watch his or her role be easily passed on to another dancer. If any support or advice is offered from the institution, it is that of staying in lean physical shape with non-weight-bearing exercises, such as Pilates, thus furthering the expectation of a lean body type on a dancer rather than encouragement of physical healing and mental health. Physical therapy sessions have been cited as a successful outlet for venting sadness and frustrations while injured. However, most dancers are unaware of the mental and emotional support a physical therapist may provide. Despite dancers' challenges in navigating these pressure-filled environments, as well as the difficulties these pressures create for dancers trying to maintain their mental health, striving for global improvement in the environment is entirely possible. The World Anti-Doping Agency has put tremendous emphasis on substance use and misuse education and prevention for athletes. Although this resource has not reached the ballet environment due to ballet not being formally recognized as a sport. When injured, many dancers strongly fear weight gain and social isolation, which contribute to psychological symptoms if treatment from injury were pursued. Thus, many dancers endure chronic pain for the opportunity to perform, rather than give up the physique and roles they worked so hard to earn, a behavior we would never observe on TV during a football game due to administration liability and different culture within formal sports. In reviewing this literature, solutions to this problem are firstly to recognize ballet formally as a sport internationally, similar to football. If this is done, great strides could be made as advocacy for athletes from organizations such as the World Anti-Doping Agency could reach ballet dancers. In addition, further efforts could be made by administrators, dance veterans, and academic researchers in the ballet workplace to pathologize, rather than continue to normalize, emotionally harmful experiences and ambiances, such as the extreme ridicule from instructors, expectation of having a certain physique, and stigmas surrounding injury. A dancer pushing their machine-like bodies through pain must no longer be rewarded. Furthermore, dance institutions need to provide mental health resources for dancers. In 2021, only one ballet institution in the United States provides a regular psychological counselor on state in the workplace. Lastly, a cultural shift towards caring for the body and mind through pain and all psychological pressures, and knowing when to stop in order to receive physical and psychological treatment needs to occur. These proposed solutions will be difficult to obtain unless research within this field is being done. Further directions for the literature include studying and publishing quantified benefits of physical therapy and psychological counseling. Barriers to implementation of this change from institution administration needs to be lowered, with stigma within the culture disintegrated, beginning with administration and mentors. Finally, dancers themselves need to be educated from a young age on injury and pathological psyche prevention. All of this will lead to dancers having the happiest long-term career possible. Here's my works cited. And thank you so much for listening. Does anyone have any questions?
Not so much a question, but I just want to say great job, and a very interesting point in terms of, I can't believe that ballet is not considered a professional sport, the amount of athleticism that it takes. And it's, I think, a basis for a lot of other types of sports and activities, for gymnastics, for ice skating, and anything, rhythmic and moving and whatnot. So excellent point. Great presentation.
May I ask a question? So first of all, thank you for your great presentation. I used to do ballet many moons ago, so it was certainly something that was of interest to me. I know you were focusing more on the short-term, consequences, the psychological, the physical. I don't know, and I don't know if your research even got this far, but what about long-term? Because we're looking at these athletes who, appear on the surface to be very physically healthy, but clearly there's a lot of mental health issues and also, the underlying drug and alcohol abuses. What about their long-term, especially once they retire, because they're not, you're not dancing into your, most ballet dancers are not dancing while well into their middle age and certainly in elderly years. But is there any evidence showing long-term consequences?
Yeah, that's a great question. Most dancers do retire by the time they are 30 or 35 because you've been training your whole life, starting at such a young age for this career, that once you're actually put through the professional pressure of that level of performance, your body can only handle it for so long. So it's very common post-retirement, even into elderly years. I worked in a physical therapy office and we treated tons of hip replacements, knee replacements in the elderly who specifically used to do ballet. So it would be really interesting to conduct a study looking at specifically retired dancers and what, not only looking back on their experience, but what it is that they're experiencing now. And I think that that could be a really interesting study to do from the physical or biological standpoint in terms of their physical health and also their psychological health.
Can I ask one more question?
Of course.
Okay. So as far as the professional dance companies go, they don't have a physical therapist that works with them on site. Do you know if they do or not? I'm kind of surprised.
Yeah, so most major international companies like, here on the East Coast, American Ballet Theater, New York City Ballet, they have physical therapists there on site. They do not have psychological counselors there on site. So that's one barrier that makes it so hard for dancers to reach out when they are struggling with any psychological issues or disease such as addiction, anxiety, depression, because they just don't even know where to go and they don't have time to go anywhere else with such a rigorous schedule. In terms of the physical therapy, there is definitely an up and coming push for more research to be done specifically on ballet dancers, because most dancers only feel comfortable going to the therapist in their company. But that I know of, only major international companies like American Ballet Theater actually have their physical therapists there on site.
Thank you.
Mm-hmm.
Carly, would you like to go next?
So I was going to say, it seems like coaches and mentors are going to be like a really important part of that change, but do you think that it's going to be a struggle to sort of get them to be the advocate for that change if for so long they've been, like requiring this like extremely lean sort of aesthetic, and it's probably something that's been like eaten into them, for the entirety of their career, and they place such a high value on that? And if that will be a challenge, like what do you think things that they could do to possibly combat that so that way their mentors and their coaches are on their side? Because I think that would be really important.
Yeah, that's a great question. This definitely came to light when I was doing my research because specifically in the United States, really all sports, if anyone here has been an athlete, even as a kid, you're taught things that your coaches were taught because of the competitive atmosphere. So there's not a whole lot of change because you want your company or your team to be more successful and uniquely successful from other teams or companies. So I think within ballet especially, that absolutely is the case. And it's really interesting looking at this research because 50 years ago, the same techniques were being taught. And it makes me personally wonder, what dancers were like 50 years ago when psychological counseling was not really acceptable. So, or maybe not 50 years ago, but around the 1950s. So I think nowadays it really starts from actual research being published, research being done on professional ballet companies, because really right now there is just not a lot. And I think that research could be, physical evidence for coaches and mentors to kind of change the way they think about things. And it would give them quantitative evidence for how their techniques have been affecting their students that maybe they didn't even think about because they were also taught in the same way. So yeah, it's definitely going to take a lot of time. That's a huge huge leap, but overall that is the goal, and it all starts with academic research.
All right, Mary, I got a couple of messages in the chat, so I'm gonna lump them all together. How did you become interested in this topic? Like, are you personally a ballet dancer? And then do you think that dancers themselves see it as a sport or as like art and identify more as athletes or artists? And then finally, do you see that there's a shift among like our generation? Like, are you seeing it progress?
Yeah, so in answering the first question, it might be clear, but I was a ballet dancer. I trained my whole life. I was a gymnast first, and then trained in ballet professionally, went to a specific high school with limited academic hours so that we could train for so many hours during the day. And then I actually came to New Jersey because I did dance professionally with a company here. So I can look in the chat regarding the second question. So dancers, I would say we see ourselves as a sport and an art, right? It's kind of, it's interesting because we're a classical performing art, but it is so athletic that it should be classified as a sport. So I would say we see ourselves as both. And regarding the last question in terms of the current generation, you know, this research to me was really enlightening because when you're in the field and, you know, with most things, this happens psychologically, when you're actually in the environment, you don't really realize how pathological the behavior is. And it has been very interesting going through this research and also realizing how little there is because you know, so many dancers, again, are kind of used to that environment. They don't even, very few dancers retire and go to school and are passionate about doing scientific research based on their field, you know? And I think that definitely needs to change. Within my own experience, while I was in the environment, that is to say, I was not, you know, completely ignorant of other girls who were struggling or other men who were struggling. I was maybe ignorant of struggles that I had myself, again, because we're taught that they're normal, but we definitely observed problems in other dancers. And my hope is that as globally, there's a complete culture change in accepting mental health, as Carly put it, accepting mental health as just as important as physical health. I hope that my generation and generations ahead of me, when they retire, they are passionate about doing this research and they are able to understand that, you know, not all of this is healthy and change needs to happen.
Well, thank you so much for your presentation. It was very informative. And thank you for all of our presentations. They were great. We have about 5 minutes if anyone has any lingering questions for any of our presenters. If not, we have a keynote speaker at 12 that we can all go to. So, thank you, everyone.
I don't have a question, but I just wanted to relate. I wrote it in the chat, but I'm not sure you guys saw it. I wanted to relate Mary and Carly's presentations together. Carly's presentation focused on a double burden of African Americans, African-American men, meaning like the burden of being a minority and the burden of having a mental illness. While Mary was speaking, great presentation, by the way, I noticed the double burden that ballet dancers would be facing is a burden of their physical injury and a burden of their psychological injuries and whatever mental illnesses they're facing, which in this case is even more unfortunate, I can say, because as we try to say, like, oh, going to a doctor for an illness in your brain is just as normal as going to a doctor for a broken arm. But in the case of ballet dancers, they're both stigmatized, which makes it that much harder to kind of deal with that. And then the pressure that you have from your mentors and performing in the best of your ability.
Thank you. Very, very, very true. Does anyone else have anything they want to add? So thank you. Enjoy the next presentation at the conference. And thank you all for presenting. Good job.
Thank you, everyone. Great job.
Thank you.
Thank you so
Great
much. Good
job, everyone. Have a good day.
The one who lies